All right, I think we're going to begin. I'd like to say hello to everyone again. My name is Andrew. I'm with Crohn's and Colitis Canada. I'm very pleased to have the opportunity to moderate today's webinar and to learn more from our guest speaker, Dr. Jennifer Jones. I'd like to start by welcoming everyone to the webinar and then outlining today's agenda. Today's education webinar on managing flares and complications in Crohn's and Colitis, hosted by Crohn's and Colitis Canada, is made possible through an unrestricted grant from Shire Canada. Some of you may be new to webinars, so I'll quickly run you through how you can ask questions and how they'll be answered. Right now, everyone is muted so that everyone can hear the speakers and so we can capture this webinar recording without audio interference. You can mute the phone by pressing *6. Please mute your phone now. I'll give you a moment or two so you can mute your phone. And if anyone has questions, they can ask. If they have any technical questions, if they have some reason why they can't hear me, you can post a question and I'll tell you how to do that shortly. If you look to the left side of your screen, in the middle, you should see a field that says questions. You can ask questions of the speaker by typing into this chat box. When you ask a question, even if the speaker is still talking, I will make a note of the question and present them when the speaker has finished their presentation. So please feel free to type out your questions as you have them, and I will read as many as we have time for during the Q&A portion of our webinar. If we don't get to your question, please feel free to follow up with us at learn@crohnsandcolitis.ca. If you have a technical question, you can also type into that box and we will follow up with you directly. Great, we're ready to get started. As I said, my name is Andrew, and I work at the Crohn's and Colitis Canada National Office. Crohn's and Colitis Canada, formerly known as the Crohn's and Colitis Foundation of Canada, CCFC for short, was established in 1974 by a group of concerned parents of children with inflammatory bowel disease. We are a national charity dedicated to finding treatments and cures for Crohn's and colitis and to educate people with these diseases and educate the public as well. We want the general public to be aware of this often debilitating chronic disease and the toll it takes on the nearly 250,000 Canadians living with Crohn's and colitis. We also want people living with these diseases to be as well resourced as possible to live well with their disease. Crohn's and colitis has funded over $82 million in research to date. This makes us one of the largest funders of Crohn's and colitis research in the world. We have more than 65,000 supporters, many of whom are actively involved in our 80 volunteer groups or chapters across Canada, and many of whom have joined us today. Today's webinar is part of Crohn's and Colitis Canada's education program, which includes live education events, patient brochures, and our website. Our education materials cover a variety of medical, social, and psychological issues related to Crohn's and colitis. We have brochures covering issues specific to children with Crohn's and colitis, ostomy care, fertility, and intimacy, among others. I will leave it at that for now, but if you would like more information about Crohn's and Colitis Canada, please visit our website at crohnsandcolitis.ca. I'm pleased now to introduce you to our guest speaker, Dr. Jennifer Jones. Dr. Jennifer Jones is an assistant professor of medicine at the University of Saskatchewan. Dr. Jones completed her gastroenterology fellowship at Dalhousie University in Halifax, Nova Scotia in 2004. Following this, she completed an advanced IBD fellowship at the Mayo Clinic in Rochester, Minnesota. She went on to complete her master's degree in epidemiology and health research methodology at the University of Calgary. Dr. Jones began her faculty appointment at the University of Saskatchewan in July 2008. Where she has taken on the role of director of the newly established multidisciplinary IBD Clinic and IBD Clinical Trials Group. Dr. Jones's research interests include epidemiological outcomes in IBD and biomarkers of disease. Dr. Jones will be speaking to us today about managing flares and complications in Crohn's diseases and ulcerative colitis. And now I will turn the webinar over to Dr. Jones.
Great. First, I'd just like to thank Andrew for his kind introduction. It is a pleasure to participate in this webinar tonight. I will admit this is my first experience as a presenter using this platform, so I will do my best to speak slowly and to enunciate. it is odd not having face-to-face contact and interaction with people and just listening to myself talk, but I'll do the best I can. Before I get started, though, I thought I would provide you with an overview of the topics that we'll be discussing. We'll be starting with a definition of inflammatory bowel disease, which I'm sure most of you know. Followed by that, we will focus on a review of some of the complications of IBD and how they are frequently dealt with. And then we'll shift to the discussion of the significance of symptoms in managing IBD, followed by a review of newer therapeutic goals in treating inflammatory bowel disease. And then we'll get a little more specific and talk about some of the more specific therapeutic options. I want to preface the talk by saying that this is basically covering an entire landscape of IBD within 45 minutes. So some of you may feel that the information is a little more superficial, but hopefully in the question and answer session we can delve in and answer some questions that are specific in more detail. Next slide, please. So IBD defined. What is inflammatory bowel disease? Well, basically, IBD can be broadly defined as any chronic inflammatory condition of the gastrointestinal tract. But for purposes of today's presentation, obviously, we'll be focusing on the two more classical forms of IBD, Crohn's disease and ulcerative colitis. Next slide, please. So what is Crohn's disease? Well, Crohn's disease is a chronic inflammatory disorder, but what sets Crohn's disease apart from ulcerative colitis is that it can involve any part of the GI tract, including structures in the oral cavity in the mouth, like the lips, the tongue, or the gums, all the way down to the lower part of the GI tract, ending in the anus or in the area surrounding the anus, called the perianal area. And this is really how the term gum to bum came to be coined, based on the extent of involvement that can sometimes occur in Crohn's disease. An important distinguishing feature of Crohn's disease, however, is that the inflammation extends all the way through the wall of the bowel. We call this transmural inflammation. And consequently, the types of complications and symptoms that patients with Crohn's disease may develop are different than those that patients with ulcerative colitis may develop. Additionally, patients with Crohn's disease can often have a very discontinuous type of inflammation in the bowel. In other words, patients may have segments of inflamed intestine interspersed with segments of non-inflamed intestine. The most frequent sites of inflammation in Crohn's disease include the small bowel, or the last portion of the small bowel, called the terminal ileum, the large bowel or colon, or both. Next slide, please. And as I mentioned, in ulcerative colitis, the inflammation is largely confined to the large bowel or the colon. So that's 1 meter of intestine that comprises the last portion of your bowel, the colon. Unlike Crohn's disease, ulcerative colitis does not affect the entire thickness of the bowel wall. So this means that just the superficial mucosal layers of the bowel wall are affected in ulcerative colitis. And in terms of location and distribution of inflammation, the inflammation in ulcerative colitis always starts in the rectum, and it may extend more proximally to varying lengths. The inflammation, as it extends proximally or further up the intestine, is also continuous. So unlike Crohn's disease, you don't tend to get these skip segments in ulcerative colitis. You can see in the 3 pictures on your slide that ulcerative colitis may be limited to the rectum. That's called proctitis, and that is displayed in the picture to the far left. In the middle, we see a representation of what inflammation confined to the left side of the colon would look like, and we call that left-sided colitis. And to the far right, we see a representation of what inflammation involving the entire colon might look like. And we call that pancolitis, or another term that is used is universal colitis. Next slide, please. And this slide really just summarizes these major differences that I have just reviewed with you. And this is really how we as physicians will try to distinguish between the two diagnoses, Crohn's disease and ulcerative colitis. And distinguishing between the two diagnoses is important and does have relevance in terms of what medications we might select to treat the conditions and whether or not specific surgical interventions would be reasonable. Next slide, please. This is a little bit blurry, but this is once again a pictorial representation of the discontinuous nature of the inflammation that involves the intestine in Crohn's disease on your far left, and in ulcerative colitis, the very continuous nature beginning in the rectum and extending up as far as it involves the colon on your right. Next slide, please. I focused on defining IBD and distinguishing IBD subtypes based on how the inflammation affects the intestinal tract. And although that is very central to understanding the condition, it's also very important to recognize that inflammatory bowel disease is a systemic disease process. So not only is the intestine involved, but other organs can be involved with inflammation as well. So patients may develop inflammatory bowel disease-associated arthritis. They may experience joint pain or spine pain involving the lower back or upper back. They may develop inflammation of the eye. They may develop skin involvement and may develop certain types of painful welts called erythema nodosum, or ulcerations on the skin called pyoderma gangrenosum. Oral ulcerations are quite common in patients with inflammatory bowel disease. They may be small little ulcers initially attributed as canker sores, or they could be more larger and more painful for patients. And inflammation can also affect the bile ducts. So these are the ducts in the liver that drain bile as it exits the liver and moves to the bowel or the intestine. There are many other extraintestinal manifestations of inflammatory bowel disease as well, but it really is outside of the scope of the presentation to delve into too much more detail about this. Next slide. This slide is really just meant to give you some pictures that give you a sense of what the extraintestinal manifestations may look like. On your top left, we have a picture of inflammation of the segment of the eye, the white of the eye called the sclera. And when it involves, inflammation involves the sclera in a very segmental way, that's called episcleritis. In the bottom left, we have a picture of an aphthous ulcer. You'll notice a white ulceration on the lower gum surrounded by a halo of red. And that is very characteristic of what an aphthous ulcer in Crohn's disease might look like. That involves the lower lip. In your top right, we have a picture of an inflamed right knee, and you can see that it's very swollen, inflamed. Quite often patients will have stiffness and soreness when they have inflammatory arthritis that is related to their inflammatory bowel disease. And in the bottom right, we have a picture of a skin condition called erythema nodosum, and that is when you may develop some very painful lumps, usually involving the lower extremities, but not always. Next slide, please. So what is the significance of this chronic inflammation? Well, if left, not only will the chronic inflammation affect your quality of life by causing symptoms, but left untreated, chronic inflammation can lead to very specific complications. These complications could include a bowel obstruction. Bowel obstructions arise as a result of the development of scarring in the bowel. Over time, just as we may develop scars on our skin from surgical incisions or from cuts or injuries, the body responds to injury in the bowel by laying down scar tissue as well. And over time, the bowel can narrow down and create something called a stricture. And that stricture can get so narrow that it's difficult for our stool and air to pass through it effectively. And this can eventually lead to a bowel obstruction. Once that has occurred, usually this can only be remedied with surgical intervention. Another type of complication that can occur is a perforation. And what that means is that you may develop an ulceration that extends through the thickness of the bowel wall, leading to the development of a hole in the bowel wall. Our environment outside of the bowel within our abdomen is sterile, and usually the abdomen does not tolerate bacteria within it. It can cause severe abdominal pain and inflammation within the abdominal cavity. So when the bowel develops a perforation, then bacteria that were formerly contained within our bowel leak into the abdominal cavities, and this can create a surgical emergency. More often, though, the body attempts to wall off any type of a defect or a breach in the bowel wall, and more often in inflammatory bowel disease, patients may develop a walled-off collection of bacteria and stool called an abscess. Fistula development essentially occurs when you have the beginning of an ulcer that penetrates through the bowel wall, but then that inflammatory process continues to extend, and it connects the bowel to whatever happens to be in this tract. And that elongated tract is called a fistula. In the diagram that I've included on this slide, you can see that there is a tract that begins as an ulcer leading to a breach in the bowel wall in the rectum and extends through the tissues outside of the bowel wall, exiting in the perianal area. And that is a special type of fistula called a perianal fistula. Management of perianal fistulae can be complicated and depends on the anatomy of the fistula, but quite often it involves a combination of both medication and surgical intervention. Other complications of inflammatory bowel disease include malabsorption, and this includes malabsorption of all forms of nutrients as well as fat and carbohydrates, particularly if the small bowel is involved, as in with Crohn's disease. But all patients with inflammatory bowel disease are at risk for either malabsorption of or loss of key nutrients. Also, patients with involvement of the colon, inflammation that involves the colon, are at risk for the development of colon cancer over time. Next slide, please. Next. Next. Back one slide, please. This pictogram is really meant to show you what the likelihood of needing surgery is in individuals who have a diagnosis of Crohn's disease. The pictogram on the left shows you what the risk of needing at least one surgery is within the first 5 years of diagnosis for patients who have been newly diagnosed with Crohn's disease. And on the right, the risk of surgery, or at least one surgery, within the first 20 years of diagnosis. And as you can see, at least 50% of people will have required at least one surgery within the first 5 years, and most patients at least one surgery within the course of their disease within 20 years. So this just shows you that the complications that I've just reviewed with you that lead to the need for surgery are prevalent and become more prevalent over time the longer you've had the disease for. Next slide. So the next slide really focuses on what the cause of Crohn's disease and ulcerative colitis is. And you really have to ask yourself, does anyone really know what causes the disease? The short answer is no. Research findings have certainly taught us that it is a very complicated process and that there are multiple factors at work and leading to disease onset. One of the key factors is obviously an individual's genetic predisposition. But we have discovered that there are more than 106 genes that could make a person susceptible to developing inflammatory bowel disease. And therefore, but no one culprit gene. These genes also tend to interact with one another as well as factors in the environment, which is the second key critical factor that is required for the development of inflammatory bowel disease. There are some key environmental exposures that appear to be implicated in the development of disease and will also potentially dictate severity of disease. For example, in Crohn's disease, smoking is associated with a greater likelihood of disease onset and a more severe disease course. The third critical component for developing disease is that of immune dysregulation. So in the right individual with the right genetic predisposition, given the right environmental exposure, this tends to kickstart a dysfunctional immune response. The research today suggests that within the bowel environment that there is most likely a pro-inflammatory makeup of our bacteria that reside within our bowel that could be implicated in the development of Crohn's disease. But the jury is still out on whether or not the bacteria causes the disease or whether the bacteria become pro-inflammatory once the disease has developed. But much more research is being done in this area as we speak. Next slide. Here in Canada, we have the highest rate of IBD globally. We still don't know exactly why this is, but many theories exist. Some theories you may have heard of include the hygiene hypothesis. So it's been observed that inflammatory bowel disease is more common in industrialized nations or nations where hygiene is greater. There also appears to be a north-south gradient, so higher rates of disease in northern climates versus southern climates. And so certainly many potential explanations, but none of this has been proven definitively yet. Next slide. So now that we've gone over a very general overview of what IBD is, we're going to shift gears and focus on understanding how IBD can affect your quality of life and how we tend to approach the management of this condition. Next slide. So it's very important to realize that the signs and symptoms of inflammatory bowel disease may be different from person to person. And this is particularly true in the setting of Crohn's disease, where disease phenotype, and phenotype really means the way that the disease behaves, can be so variable. So for example, in an individual with Crohn's disease who has a predisposition to develop scar tissue or stricturing, and as you may recall, that scar tissue is what can lead to bowel obstruction, those individuals are more likely to present with symptoms of obstruction. For example, increased abdominal bloating, nausea, and abdominal pain, versus an individual who has more extensive inflammatory involvement of the colon and or small bowel. Those individuals would be more likely to present with symptoms of persistent diarrhea, perhaps some rectal bleeding, abdominal cramping, frequency, and urgency. So it really depends on the behavior of the disease as well as the location of disease. In ulcerative colitis, symptoms tend to reflect a little more strongly what is going on in the bowel in terms of how active inflammation is, but not all the time. So symptoms for individuals may include abdominal pain and cramps, rectal urgency, frequent diarrhea, blood and mucus in the stool, increased gas, persistent fatigue, weight loss, fever, and the development of complications like we just discussed. Next slide. If you're an individual that has learned that your symptoms tend to reliably tell you that your IBD is active or that you're experiencing an inflammatory bowel disease flare, then it really makes sense for you to note the development of your symptoms from day to day, week to week, and to try to track those symptoms to determine whether symptoms are getting worse, whether they're occurring more or less frequently, or whether you're developing any new symptoms. This may help you to identify the beginning of a disease flare, and it also can help you to gauge your response to medical therapy. Next slide. It's also important to note that you may or may not experience symptoms for many months at a time. As is typical with this condition, quite often the condition can go into remission and stay in remission for weeks to months at a time. And usually the disease course is characterized by flares interspersed with periods of remission. When you do have a flare-up, the symptoms may not always be the same. The severity may not always be the same. So it is helpful to keep a journal to keep track of flare-ups, your symptoms and their impact on your daily life, and to discuss these symptoms with your physician. But I've put in bold and in capital letters here that many patients do not exhibit symptoms even though they have active inflammation in your intestine. And this is probably the most important message to take home from the discussion about symptoms in today's presentation. The converse can also be true. Many symptoms who exhibit a great deal of gastrointestinal symptoms may or may not have a significant amount of inflammation or any inflammation in their intestinal tract. They may have other issues that are driving their symptoms. Next slide. And for this reason, your doctor may quite frequently want to use other objective measures of inflammation in order to determine what's going on in the intestinal tract. So symptoms are a very important component of evaluating you to determine what's going on, but other objective measures of inflammation, including endoscopy, which may include colonoscopy and gastroscopy, biomarkers of inflammation, which are basically just proteins that are naturally occurring in the body that tend to go up when the body has inflammation. These can include blood tests such as C-reactive protein or stool tests like fecal calprotectin, or your doctor may want to use imaging studies, so indirectly visualizing the small bowel through the use of a CT scan or an MRI, for example. These objective assessments can certainly give us a sense as to severity of intestinal inflammation, the disease location, and the presence or absence of complications that may have developed. Next slide. So moving on to medical treatment, which is what most of you are probably interested in. Next slide. Before discussing specific medications, it is important to take a step back to understand what the goals of medical therapy are in 2014. In probably more than a decade ago, the goals of therapy were to keep you out of hospital. And really, the bar in 2014 has been set even higher. So staying out of hospital does not mean that you have good quality of life, does not mean that you're feeling well. So in 2014, the goal is really to affect the disease has on your life. It is to keep the symptoms of your disease under control by reducing flare-ups and inducing remission. And we've also set the bar even higher by identifying the importance of healing the inner lining of your bowel. We call this mucosal healing. And we have learned that if we are able to heal ulcerations in the bowel, that this can lead to longer periods of remission and overall well-being. And it also has been shown to be associated with reduction of complications and a reduced need for surgery. Next slide. So this slide depicts how most people with IBD will be affected. Next. You can see that on the vertical axis we have disease activity, and on the horizontal axis we have time. And most patients over time will flare and remit. And the severity of flares and the length of time between flares tends to be different for every individual. The green line that you can see intersecting the horizontal axis is really an artificial way of dividing up how we view medical therapy. So induction therapy really is therapy designed to control symptoms quickly. And that is therapy that is given during a short period of time at the beginning. Maintenance therapy is really therapy that is designed to maintain clinical remission once you have achieved it with induction therapy. Next. Next. So you can see that the pink triangle on the left is representative of induction therapy with a medication, and the purple arrow is maintenance therapy. So this is a drug designed to maintain control of disease over the long run. And although a perfect drug would do all of this for us and have zero side effects or zero potential for harm, unfortunately, such a drug does not yet exist. But we seem to be getting a little bit closer as every decade goes by. Next slide. So this slide is somewhat repetitive, but I think the key take-home points from this slide is that therapeutic goals can be divided into short-term and long-term goals. In the short term, we want to make sure that the quality of life is positively effective and that patients are feeling well without the need for corticosteroids. And I'll discuss why this is important in a few slides. In the long term, it's very important that we aim to minimize the development of complications through healing the lining of the bowel wherever possible. And this may help to reduce hospitalizations, the need for surgeries, and the need for expensive care. Next slide. Once one has attained a clinical remission, it's very important to continue on whatever maintenance therapy you have discussed with your healthcare team. And that's why we call it maintenance therapy. And that maintenance therapy is designed to keep control of disease over the long run. Inflammatory bowel disease is a chronic condition. Unfortunately, there is not yet a cure, but we certainly have the medications that can help to control disease over the long run. We do know that withdrawal of therapy is associated with a greater likelihood for disease relapse and lower likelihood of maintaining clinical remission. Next slide, please. We talked a little bit about mucosal healing, and I just wanted to speak to it for a moment. Mucosal healing, although it has become a therapeutic goal of many in inflammatory bowel disease, I just want to clarify what significance it really has. Mucosal healing really refers to the healing of ulcerations within the bowel. So if we see ulcerations before you start a therapy, if we were to repeat your scope after a therapy and we see that these ulcerations have healed and have disappeared, we would define that as having achieved mucosal healing. There may or may not be some degree of residual inflammation, but the ulcerations are what really portend a more severe disease course and a greater likelihood of developing complications. Next slide, please. This is a pyramid that we created in our clinic here, and it's really just meant to represent for you the traditional one-size-fits-all approach to treating IBD. And in this approach, we start at the bottom of the pyramid, regardless of the individual, the nature of their disease, regardless of how many surgeries they've had, and regardless of what they've been on before. We start at the bottom of the pyramid and we work our way up rung by rung until we get to the top. And I just want to make sure that you understand that only therapies with reasonable, high-quality clinical trials to support their use have been included on this pyramid. There are many other treatments, both pharmaceutical, nutraceutical, that means nutritional interventions, and alternative or homeopathic that we could discuss at length, but it's outside of the scope of this presentation. So just so you're aware, that is why we're focusing on these medications on this pyramid. Next. But this X is really meant to personalize, or really meant to signify a shift in our approach to managing inflammatory bowel disease. And this shift began approximately 7 years ago. In 2014, we really approached IBD in a more personalized way. So our goal is to consider individual characteristics of disease and individual tolerance of medication to come up with a management plan. Next slide, please. So we'll take each class of medication one by one, and I'll give you a general overview of what the medication is, how it works, and how well they work as induction therapies and maintenance therapies. And if you remember from that graph that I just showed you, what we are referring to when we are using the term induction and maintenance. Just try to picture that graph in your mind. So the first class of medication are called anti-inflammatory medications. And these are probably one of the better known treatment options, and they've been around for a very, very long time. And they are inclusive of 5-ASA medications. These are medications like Stalofol, Asacol, Pentasa, Misavent. The list goes on. And really, 5-ASA medications have been shown repeatedly to be excellent for both induction and maintenance of remission in ulcerative colitis. And they continue in 2014 to be the mainstay for patients with mild to moderate severity ulcerative colitis. Other than in cases of the mildest form of Crohn's disease, 5-ASA medications have been shown to be relatively ineffective, but yet they still are prescribed quite frequently. But if you're actually really looking for information about whether or not there is research to support the use in terms of efficacy or how effective the drug is, 5-ASA medications really are useful for ulcerative colitis and not as useful in Crohn's disease. Next slide, please. Corticosteroids are very, very effective induction agents. They get control of inflammation quickly in patients with inflammatory bowel disease. They are one of our only effective forms of induction therapy that we have readily available to us. They work by suppressing the immune system and are used to treat moderate to severely active inflammatory bowel disease. But steroids, although effective in the short term, they are effective in reducing swelling but are not meant for long-term treatment. And this is for multiple reasons. Firstly, they have very frequent side effects that can be divided into both short-term and long-term side effects. Certainly in the short term, they can cause symptoms such as mood disturbance, sleep disturbance, weight gain, irritability. But it is the longer-term side effects of steroids that we get more concerned about. And these include side effects such as thinning of the bones or osteoporosis, high blood pressure, the risk of developing glaucoma, diabetes, etc. Not only are they associated with a high frequency of long-term side effects, but they have been shown to be ineffective if used long-term. So corticosteroids, medications like prednisone, are really meant for induction of remission and to use as an agent to transition you to a more effective maintenance medication. So a maintenance medication that can keep you in remission that has fewer long-term side effects. Next slide. The next class of medications are called immunosuppressants. They're also known as immune modifiers, and they really block the immune response that causes inflammation. And two examples of these are azathioprine, or Imiran, and methotrexate. They tend to be used in individuals who have moderate to severely active Crohn's disease who have not done well with lower-level forms of treatment. Immunosuppressants have been shown to help decrease steroid use in the long run and definitely have fewer long-term side effects than medications such as prednisone. Therefore, they're more desirable as medications to control or maintain disease remission over time. But both of these medications, in particular azathioprine, are very slow to take effect. They take some time to work. And for this reason, they are not ideal as induction agents. So they're not ideal to get your symptoms under control quickly. Azathioprine takes approximately 10 weeks to take effect, and methotrexate, although it takes less time, 6 to 8 weeks, still takes much longer than a steroid would take to induce remission. Next slide. The next class of medication are called biologics. And really all that biologics are proteins called antibodies that are normally found in our body whose role is to attack foreign invaders. And what scientists have done is they have engineered their own antibodies to target a very specific part of the immune system. One particular type of biologic therapy involves targeting one specific chemical messenger called tumor necrosis factor alpha, or TNF. Some of the more readily available biologics that are currently available in Canada, like infliximab or adalimumab, work by this mechanism. But not all biologics work by this mechanism. Anti-TNF medications like infliximab or adalimumab or golimumab have been shown to be some of the more effective induction and maintenance medications that we have to date. So biologics, like the anti-TNF medications, do tend to induce remission quickly and are effective at maintaining remission. However, because these are not your proteins, they are foreign proteins, your body will launch its own immune response to the medication. And over time, there is a risk of losing response to the medication. So we tend to get a drop-off in the benefit in terms of maintaining disease remission in those who have responded initially. Other biologics are coming down the pipe, have recently been approved or will be approved, or are in development right now. So other biologics that work differently or have different mechanisms of action are in development or will become available soon. Next slide, please. Surgery, although not a medication, I just add surgery here, just really to outline a few key points. One is that in this day and age, surgery is generally viewed as a last resort, particularly in Crohn's disease. In Crohn's disease that involves the small bowel and colon, after surgery, the disease does tend to recur. Approximately 70 to 80% of patients will have evidence of recurrent ulceration inflammation within a year of having the surgery. So even surgeons in this day and age recognize that surgery is not a long-term curative intervention. And in most cases, they would recommend that we at least try, take a reasonable attempt at treating with medical therapy. There are some exceptions to this rule, but the majority of individuals will develop disease recurrence after surgery. The surgical indications or indications to perform surgery for IBD are really limited to the development of complications that really can't be effectively treated with medication. It is the goal of therapy to avoid the development of complications, but obviously in some individuals, complications have developed before therapy has started. And in these individuals, most likely surgery will be required to deal with it. Next slide, please. So really the take-home message that I want to leave you with about medication and treatment for IBD is that education is power. Really, decisions about how to treat IBD are personalized. They must be reached after discussion between the patient and their healthcare team. And the patient really needs to be knowledgeable about the potential risks and benefits. To be educated and knowledgeable about your disease is key. To be insightful about how the disease affects your life and what the significance of your symptoms are is very important. And it's very important to use reputable sources of information upon which your critical decisions are going to be made. So ideally, sources of information that are supported by reputable organizations, such as the Crohn's and Colitis Foundation or key medical organizations that really use a strong basis in scientific evidence for their recommendations and their information. Decisions about therapy are personalized. So really, you know, a number of factors need to be taken into consideration before deciding on how to treat a flare or how to choose a maintenance medication. So how severe is the disease? Where is it located? Have there been complications that have developed? What is the severity endoscopically? How severe are the symptoms? How does the disease behave? And we remember that this is called the disease phenotype. How many surgeries have been performed? Will this person tolerate the medication? Does this person want to become pregnant? Are there other lifestyle or life goals that need to be taken into consideration when deciding on an approach to management of the condition? Next slide, please. And don't be afraid to ask clarifying questions of your healthcare team or healthcare practitioner. Very important to help you to make an informed decision about your management. Next slide, please. So I just want to thank everybody for sticking with me and not falling asleep. Well, maybe you did. I can't see you, so I wouldn't know anyway, during this 45-minute session. We'll stop here, and I presume that now we'll be able to field some questions.
Thank you, Dr. Jones. Before we get to the questions and answer period, I wanted to remind everyone about World IBD Day and the next webinar. Our next webinar is on Monday, May 19th, World IBD Day, and will be on the topic of probiotics and nutritional supplements for Crohn's and colitis. Learn more about how probiotics impact Crohn's diseases, which nutritional supplements are beneficial to these diseases, and much more. You can visit crohnsandcolitis.ca/webinar for more details and to register. Other ways you can show your support for World IBD Day is to visit our Facebook page or website to download your own Crohn's and Colitis Canada Facebook cover photo and profile picture. Upload to your very own Facebook page to show your friends and family that you support the over 200,000 Canadians and millions worldwide living with Crohn's and colitis. And now we're going to go on to the question and answer period. We will now open the floor to any questions that you may have for our speaker. And the first question that I have is from Gloria, and she asks, are there other drugs besides Imurin that can help? Dr. Jones?
Oh, yes, sorry, I thought there was more to the question.
Oh,
So thanks for that question, Gloria. I hope I was able to address most of that question in the form earlier in the discussion, but obviously the answer is yes. So I'm not sure if we're talking about Crohn's disease or ulcerative colitis, but for IBD in general, there are the numerous classes of medications that I reviewed that could be helpful depending on your particular circumstances. So those include the biologics, potentially the corticosteroids for short-term treatment, and 5-ASA medications. There is a newer class of medication that will be approved in Canada later in 2014. You may have heard of the medication. It's called vedolizumab, and vedolizumab is another example of a biologic that works differently than the anti-TNF medications do. Vedolizumab works by preventing harmful white blood cells from trafficking to the gut. So if you can imagine our blood vessels as highways and imagine our white blood cells as cars that are traveling along those highways, there are special proteins that line our blood vessels that our cars, or white blood cells, will actually stick to before they get off on the off-ramp, if you will. So there are certain proteins that signal white blood cells to enter the tissues in the intestine. And so vedolizumab basically works by preventing white blood cells from getting off the highway and getting into tissues in the intestine. And it's been shown to be fairly specific for the intestinal tract, in that the clinical trials looking at its efficacy, both for induction and maintenance of disease remission, met their endpoints. And it was approved in the United States in February of 2014, and it is likely to be approved before the end of this year, sort of last quarter of 2014. So we will have very soon another medication available for treatment of more severe forms of inflammatory bowel disease either. Also, it's certainly not a first-line therapy. And it is will be approved probably for both indications for ulcerative colitis and Crohn's disease as well. And there, as I said earlier in the presentation, there are numerous medications under study, and that will be coming down the pipe as well in the future.
Marion asks, please give information on managing constipation when diagnosed with Crohn's.
Okay. So, you know, some of these symptom management questions are a little challenging because it really does depend on your individual circumstances. So the advice that I'm going to give is actually quite generic, and I'm hoping I'm not missing some of the information that is relevant to your particular case. But it really depends on what's causing the constipation. So if you have a mechanical cause, in other words, if you have a stricture that is leading to an obstruction of flow of stool that is causing constipation, then obviously that stricture would need to be dealt with. It would need to be dilated and to alleviate the blockage to the flow of stool. If that isn't the case, if you have a bowel that is inflamed, quite often inflammation involving the rectum, in the case of ulcerative colitis or Crohn's disease, can cause constipation. In that setting, getting adequate control of the inflammation in the rectum can quite often alleviate symptoms of constipation. If your scenario is one in which you have had inflammation but have had successful medical treatment and your bowel is now in remission, in other words, there is no active inflammation present anymore, then sometimes the constipation you're experiencing can be as a result of impaired motility of the bowel. So sometimes that can take the form of irritable bowel syndrome with a constipation predominant subtype. If that's the cause of the constipation, then quite often a bowel regimen can be recommended. And bowel regimens that are generally safe for long-term use include the use of special types of laxatives called osmotic laxatives. So these are medications like milk of magnesia, lactulose, that tend to pull water into the bowel, but they don't stimulate muscle contraction, because over time stimulating muscle contraction can actually make constipation worse and impair the motility of the bowel further. In more severe forms of constipation that aren't responding to dietary intervention, high fiber diet, regular physical activity, and or the use of laxatives, then sometimes we have to use more potent medications that actually stimulate gut motility. So I hope that helped answer your question. That was I was trying to field all potential scenarios in answering that question.
Terry asks, if you first had UC, but then you were diagnosed with Crohn's, do you have both types of inflammation?
Okay. That's an excellent question. And the answer is a little bit complex. We can say with 100% certainty that if you have the characteristic features of Crohn's disease, that you will always have Crohn's disease. So if you have skip segments, transmural inflammation, biopsies that are confirmatory for the condition, and it affects the bowel in the right place, we can say that that is Crohn's disease. Ulcerative colitis is a little bit different. Ulcerative colitis can mimic, or I should say Crohn's disease rather, can mimic ulcerative colitis. There is a subtype of Crohn's disease that we call ulcerative colitis like Crohn's disease. And the reason that we have actually coined that term is because it looks and behaves in every way like ulcerative colitis. But there is either another feature, or eventually over time, patients will declare themselves as actually having had Crohn's disease. So for this reason, we're very, very careful about making sure that patients understand that we can never be 100% certain that when they present with a diagnosis of ulcerative colitis that it is ulcerative colitis. We can be near certain, but we can never be 100% certain. So it's possible, without knowing the details of your case, it is possible that in your case you may have had an ulcerative colitis-like phenotype of Crohn's disease that eventually over time declared itself as Crohn's disease. I'm just sort of taking a guess, but that would be the most obvious explanation in your case.
Jillian asks, would these extraneous conditions, arthritis, etc., occur only when there is a flare-up of IBD or independency?
That's an excellent question, and it really depends on which one you're talking about. So let's take the case of arthritis, which you just mentioned. So there are different types of arthritis in IBD. So there is what's called a peripheral arthritis. So that means that the peripheral joints are involved. So not the spine, but knees, shoulders, ankles, what have you. The larger joints that are peripheral in location, when they get inflamed, oftentimes you'll get what's called a migratory arthritis. The arthritis will move around. So that type of arthritis almost always is associated with active inflammation. So when you start to get that type of arthritis acting up, it usually means that your bowel is becoming inflamed, whether you're having symptoms or not. And so that can be another way of gauging whether or not your intestinal inflammation is under control. There's another type of peripheral arthritis that is actually usually confined to the small joints of the hands, for example, the fingers, that tends to be symmetrical, so both hands are involved, and fixed, so it doesn't tend to move around. And that can almost sort of mimic a rheumatoid arthritis type of inflammation, but it's not. But that particular type of peripheral arthritis, that second type, does not parallel disease activity. So in other words, it is not associated with what's going on in your bowel. Then we have a third type of arthritis, and that is arthritis that affects the spine. And we call that a central arthritis. And central arthritis may or may not be associated with bowel activity. And it's important to reevaluate the bowel if you're suffering from that form of arthritis. Oral ulcerations, ocular inflammation, eye inflammation, that all tends to parallel disease activity. In other words, if you've got ulcers, if you've got inflammation in your eyes, usually there's active inflammation in the gut, whether you're symptomatic or you are not symptomatic. I hope that helps to answer your question.
I think we have a time for one or two more questions. Sharon asks, I seem to experience flare-ups of my colitis when my spring allergies appear. Is there a connection between seasonal allergies and IBD? Do antihistamines have any effect on calming IBD flares?
That's another really great question. I have a lot of patients that, not a lot, but I've had a number of patients over the years who have reported that pattern to me, having flares of their, seasonal flares of their inflammatory bowel disease. The literature, meaning that the research that has been studied, that has been published to date with respect to exploring patterns of disease, don't support that. In other words, they don't prove that there's a link between the time of year and the likelihood of developing flare. But anecdotally, just in my own practice, I've had a number of people over the years who have reported that. Antihistamines, no proven benefit as of yet in the treatment of inflammatory bowel disease. But, you know, everybody's different. And ulcerative colitis and Crohn's disease are really arbitrary distinctions that we're making here. And inflammatory bowel disease likely includes a host of inflammatory conditions involving the intestinal tract that over time we may end up labeling as IBD subtype 1 through 20. So there may be a subtype of IBD, for example, that may not occur as often as the other subtypes, that does indeed have an allergic component to it and that is influenced by seasonality.
George asks, and this is probably the final question that we have time for today, is there a perspective for new treatments on the go? I heard of a treatment by antibiotics and some sort of capsules of feces inoculated and prepared on an individual basis.
Yeah, so one was about an antibiotic and the other was about the stool, well, not transplant, but capsules of feces, yeah. So there are lots of studies going on right now that center on the role of the microbiome in disease onset and treating disease. So fecal transplantation, whether it's via an enema or the delivery through capsules is an example of that type of research. There are randomized controlled trials going on right now where patients are going to be randomized to such an intervention versus not in Canada and in the U.S. Right now, the only absolute indication for fecal transplant is in the setting of refractory or treatment-resistant infection called C. difficile colitis. Now, patients with inflammatory bowel disease are at risk for C. difficile colitis, and in some selected cases, patients with IBD who have that infection might be considered for a fecal transplantation in the right center. But as far as whether this is a practice or an intervention that we can use effectively, safely in all patients with IBD is really not known yet. But hopefully over the next 1 to 2 years, we'll have more information on that topic as these trials come to their conclusion. Antibiotic therapy, really to date, the research on antibiotics has been disappointing in terms of controlling disease long term. There are certainly people who report improvement in symptoms when they take antibiotic therapy, especially with certain patients with Crohn's disease. But if you look long term, the antibiotics tend not to work very long in controlling the symptoms. If options are limited, there's certainly no harm in using antibiotics intermittently to control symptoms. But long term, they tend not to have sustained benefit. There are some newer antibiotics, however, that are being trialed in the setting of Crohn's disease. And hopefully we'll have more information as to whether or not these newer antibiotics may have a role in induction and maintenance of remission in inflammatory bowel disease.
All right, great, thank you. As we're drawing near to the end, I'd like to take the opportunity to let everyone know that we will be following up with everyone after the webinar via email to get your feedback and any suggestions you may have for future topics. And this concludes today's webinar. I want to thank everyone for being with us today and for the great questions. I especially want to thank our speaker, Dr. Jennifer Jones, for taking time out of her busy schedule to share her expertise and knowledge with us all. Also, thank you to Shire Canada for supporting this webinar. A recording will be made available for downloading on our website at crohnsandcolitis.ca/webinar. Crohn's and Colitis Canada also hosts education symposiums across Canada every November, so be sure to visit crohnsandcolitis.ca/symposium to find out more. I encourage everyone to join us on World IBD Day, Monday, May 19th, for our webinar on probiotics and nutritional supplements for Crohn's and colitis. Please go to crohnsandcolitis.ca/webinar for details and to register. I also encourage everyone to join us Sunday, June 8th, for our Crohn's and Colitis Gutsy Walk. Thousands of Canadians at nearly 70 locations across the country will walk together to raise money to find a cure for Crohn's and colitis. Visit gutsywalk.ca to participate, fundraise, donate, or volunteer. Again, thank you very much for joining us. I hope we helped answer some of your questions about living well with Crohn's and colitis. This concludes today's webinar. Thank you very much, everyone.